Hello, and welcome to the Virtual Learning Academy. This is topic 4, what to do when the fully guided prosthetic kit arrives, the dry model surgery review. I'm Jeff Carlson. I am the Senior Implant Representative for National Dentex, and I'm so happy that you took time to review this. The purpose of this presentation is to help you get familiar with all the parts and pieces, and very importantly, by doing this a few days ahead of time of the scheduled surgery date, you also know if you have the right components, the right tooling to perform the case. So let's get right into it. I do want to note that this case we'll be showing you is just a demo case. It's a maxillary 5 implant case. Of course, this may not reflect exactly what your case is, but you get the idea of it. I do have to pick some particular case to take you through the step by step. So don't get caught up if the numbers don't match or the implant sites don't match, meaning the tooth numbers, etc. But the workflow is exactly what we'd like to see you be doing with your case. And I'm going to be showing you a couple variations to this as well. The kit, first off, is going to arrive in a box. The components have all been labeled and organized. And when you open your box, there'll be this large white envelope. And very importantly, that you go into this, look through this envelope. It has a lot of documents, a lot of important information for you to review prior to surgery. I'm going to take you through some of the key parts of the items that are included in that envelope now. So in that information folder is what I like to call it. You're going to have the a lot of reports. You're going to have photographs. At the laboratory, we actually photograph all the different steps of your case so that you can actually physically see what it looked like at the laboratory so that when you're doing it, you have kind of a reference point. Albeit when you're in live surgery, sometimes things are slightly different, but you'll get the idea of the flow and in general how things should look. The bottom two images are an example of there'll be an 8 by 10 sheet in there that will actually show you when you're lining up the multi-unit abutments how they should line up to the blue lines. The far bottom right one is showing you how a marking on a reference point on the implant driver would help you for the timing or the rotation of the implant that you're placing. There's a sheet in there that's going to be like a summary sheet, and it'll be specific to your case. But what you're seeing here, what I think is important for you to look at is make sure that these are the implants that you have in inventory, and you should have some backup ones too. Might be something that maybe you drop an implant, or maybe you need a wider implant. You didn't get enough initial stability. You need to go up one implant wider. So you want to make sure you have backup components. The abutment size, as you see on the right, that's showing you that first one says it's a 30 degree, cuff height is a 2.5. And for whatever particular implant system you're working with, we'll have the part number right there for you as well. Now, when you do the fully guided in sequence kit, we have already ordered the prosthetic components and have customized them as necessary for your particular case. We do indicate to you what implants you need to order. We do not order the implants for you. The clinician is responsible for ordering the implant. When you're doing what is called a Simply Guide Plus, which some of you may do or have done, please note that no prosthetic components are included with that. You would simply receive a sheet like this telling you what the abutments would be, the angulation, the cuff heights, etc. And it's up to you, the clinician, to order those parts. Now, that's just with what we call the Simply Guide Plus. So for this exercise, we are actually going to be focused on the fully guided in sequence prosthetic kit. Also, there's a sheet in there that's very important. I think many clinicians overlook this simply because they don't know the value of what we have here. So I want to take you through what you're looking at. This is called the bone density and implant position. And you'll have one sheet like this for each implant site. For an example, this would be for tooth number 13. Um, it'll tell you the size of the implant. It will tell you the angulation of the implant. Um, the no collision, that's just a default that the software does. That would only, you don't need to worry about that. understanding what that means. But what I do want to bring your attention to is that this box here, this red-green box, um, for example, this implant is a 12 millimeter length implant. And this box represents 12 millimeters of uh, vertical bone. In other words, this is the crest of the ridge after bone reduction. And this would be the apical of the implant. So this is 12 millimeters of bone. Regardless of how it looks on you, it's always going to be the same on this form, but just know that that is what it represents. So this is the platform of the implant, and this is the apical tip, if you will, of the implant. Now, this chart is divided. The brighter red is D4 bone, and then you have D3, which is more of a maroon color, and then you have a D2 bone, and then the D1 is the lighter green, and that's the majority of this graph here. Now, what you're going to see is based on the bone density, this line is done by the software, and it'll tell you that, for an example, this particular case, that the crest of the ridge, going probably, maybe three, as much as 3 millimeters subcrestal, will be D1 bone. But also, just as we know, D3 bone, D4 bone, typically your maxillary arch, um, will have the apical be a little bit softer bone. So this is showing you that almost half of the implant is going to be in D3, and a majority of it, the apical one-third at least, is going to be in D4 bone. Why is that important? That will help you to determine your drilling sequence. I'll talk about that on the next slide. So know that this is the platform of your implant, and this is the apical of your implant, whether it was an 8 millimeter, 15 millimeter, it's always going to reference the same. Now, these three cross-sectional images here, what you're looking at here is pay attention really to this center image. This center image represents the center of your osteotomy. The image to the left represents the slice at 1.5 millimeters to the mesial, and the image here on the right is 1.5 millimeters to the distal from the center. So usually focus on the center image here. And then the one far right here is basically just kind of a pano shot or a buckle view to let you see how close you are. For this example, you can see the sinus here, um, so forth. Now, when I mentioned about helps you with your drilling, is that now this was an actual case. And so since we knew that we had pretty dense bone here for the half of the implant, the coronal half, if you will, and then the apical half was in softer bone, especially, the majority of it was in D4 bone. So based on your implant system, whether it's one of the more aggressive threaded implants, just the thread pitch, thread design, you'll need to make the determinations as far as undersizing. What this chart is doing is help you to have a good idea of what bone you're going to get there. So it's between having this chart, looking at the bone actually on your drill, give you an idea. Of course, the white bone on your drill is D1, reddish bone is D2. If the bone is more like what I call a slushy on your thread, drilling your threads of your drill, then that would be more like a D3. And usually we see if it's D4 bone, really no bone stays on your drill when you come out of the osteotomy. And then also, of course, you're going to use your tactile feel to get an idea of the bone density. So this chart is just another reference for you to help determine the bone density. This particular case, we decided that we had a case. This was a tapered probe. This was an aggressive threaded implant. And so this is a similar concept with your aggressive threaded implants. But for an example here, we went to 2.0 to depth. And these are just notes that I wrote during the surgery. And then we did the next drill, we did a 2.5 to depth. And then we thought, because you can always take more bone out, you can't put bone back. And we need to get good initial stability to be able to load these implants on the day of surgery to give that patient their provisional on the day of surgery. So we went to the next, for this system was a 3.2. We went to half depth with that 3.2 and tried placing the implant. And we found that we were able to place the implant, and we actually got a little bit more than 40 plus Newton centimeters of insertion torque. So we wrote that on there, and this actually kind of becomes a recipe, if you will. If you have other implant sites that have this similar bone density chart, that kind of gives you an idea. But it's a very important to just, understand how to utilize the information that in sequence is providing for you to make as much of informed clinical decisions as possible. That's what our goal is here. The other thing to think about is when you do, let's say, have to maybe you want to think about upsizing the diameter of the implant to get better stability. So you're looking at that center image, I just blew it up here over to the right, and you'll notice that the lab will outline, the blue will outline the bone, yellow is your implant, the orange is the MUA, and then the pink represents the body of the provisional, and of course the white's the tooth. So if you're wondering if this case, let's say you didn't get real good stability and you want to think about, can I go to a wider implant? Well, if you look at this, the buccal, there's not a whole lot of room here, but palatally, you have a little bit more room. So if you use the surgical guide and we're able to place a wider implant through the sleeve, some implant systems, based on their designs, the sleeves may be the same for a one implant wider or one implant narrower. It just depends on your implant system. Uh, but if you use this particular guide and place that wider implant, you may perforate on the buccal. So it's a visual aid for you, again, to help you to make clinical informed decisions. So now when you're looking at your kit, this is how the kit's going to be organized. And you have, we're going to go through all the items that are in here, obviously. But I do want to note that what you're looking at this system, again, I had to have, we have to select some case, and it happens to be that a lot of our hands-on kits that I'm using this as a model for is with the Neodent implant system. But the workflow is going to be the same regardless of implant system for the most part. Yeah, regardless what implant system you're working with. So in your kit, you're going to have your working model and then what we call a bone cut model. And we're going to cover all these in depth. An opposing model, your surgical guide. With the full in sequence guided kit, you're going to get two long-term provisionals, which we refer to as LTP, long-term provisional. Then in the middle row, you're going to see a pre-surgical model. That's how the patient presents to you at the day of surgery. And then there'll be a monostrut, it could be a tooth supported or a bone supported. The start bite, angle rotation guide, which is going to help you for positioning the multi-unit abutments for the right position, and a tissue gasket, which is going to act as a rubber dam to protect the surgical site. And then your bottom row, you have your bone foundation guide. And then your components would be all labeled by your prosthetic components for each implant site will be labeled. You're going to receive in each box, crown box, you get one of the multi-unit abutments, whether it's a straight or an angled. Then you'll get two temporary copings or temporary cylinders. You'll get two of the small prosthetic screws and two blackout plugs. This is per implant site. So here's what I'd like you to do. Let's begin the actual exercise. So hopefully you have your kit out in front of you. If not, pause this right at this time and go ahead and get your box and open it up. And let's go ahead and begin our exercise. So the first thing I'm going to ask you to do is to remove the two printed models. You're going to have your working model, which my example is a maxillary case we're doing. You may have a double arch, so both of your models may be working models. And then your opposing model. So get those out. And notice that the base of the models have mounts on them. So when you did your digital prescription, there's a spot to indicate what articulator, semi-adjustable articulator you'll be utilizing. And so this will actually be able to, you could mount it onto your articulator. For example, if you were using a Stratus articulator or a SAM2 or whatever articulator that you're utilizing, Panadent, etc., then this would fit to that. There's a magnet on the bottom of the model. So you could actually use the articulator if you'd like to do that. I'm not showing that with this system, with this presentation. Basically, just kind of give you where you're going to hand hold the models as we're going through here. So the first clinical step that you would be doing, this is prior to sedation. It's a very important step that many clinicians miss, and it's the trying in of the start bite. And the start bite is a hard replica of the bite registration that the laboratory received. Now, if you are a specialist and you're doing just the surgery and you're reviewing this case, please note that then your restorative doctor would have sent in this, or maybe you did the case, the workup, and had the bite registration. But either way, and if it was all digital and you didn't send physical bite registration in, if it's all digital, we print this and we make this a hard replica. So at the laboratory, we work in both a digital world and an analog world at the laboratory. And so this is going to be our ability to say to you right now that, Doc, this is the bite registration we're working with. So let's take a look at that. Um, so what you're going to do is remove the large indenture box that's in the front. If you're holding your box like you see here on the slide, and that's going to say whether maxillary mandibular, but in there is going to be several models and components. So open that up and take out what we call the pre-surgical model. And your working arch, if it's a double arch, you're going to have two of these boxes. One will be for your maxillary arch and one will be for your mandibular arch. So they'll be laid out the same. It's just that you'll have two of these black boxes. So if you look at your pre-surgical model, you'll notice there's three pegs that are protruding from the integular side of that model. Now, and then you just see the occlusal view. So again, this is how they present at the day of surgery. So what we're going to ask you to do is look at your working model, and you're going to see there'll be three square recessed holes, if you will, where those points those protruding points will fit to index you into the working model. So go ahead at this time and seat that, identify that. Sometimes I find it's helpful to go ahead and take a Sharpie and just take a black Sharpie or a red Sharpie, either way, and outline each one of those little squares. So when you're in the operatory, pardon me, and the bright lights, sometimes it's hard to see that if you're wanting to line it up. But by doing that and also taking that black Sharpie, and I like to highlight this with some black Sharpie so you can see those protruding points really easy. So now you see the outline, makes it really easy to index, kind of putting the puzzle together quick and easy. So go ahead and seat your pre-study, your pre-surgical model onto your working model. So as you see here on the right. Now go ahead and remove the start bite. Most often you're going to find this the very front denture box here, and take out your start bite. Again, the start bite is the hard replica of what we received from the clinician. And you're going to go ahead and seat that onto this is kind of irrelevant when you seat it on the upper, seat it on the lower. This is just, if I'm doing it in the mouth, I'm going to show you a video coming up next here on the next slide of how we do it intraorally. But for your hands-on exercise here, seat it onto the upper model. Then you can just this is where you kind of do the juggling act and then line it up. And as you see in the right, we're just kind of freehanding, holding the models together on a model like this, or even on your articulator. If you had your articulator, it's more helpful. But if you're not putting it on the articulator, you don't have it available, um, this just kind of gives you an idea what we're doing. It's not real beneficial because you could move it around and may not be exactly the way the patient's bite is. Um, but let me just show you this quick little video here. And this is very important, especially for my specialist friends that many times I'll see where maybe the patient, based on your assistant's certifications, what have you, they may already been sedated, or you may have sedated the patient and then come back in. This should be done prior to any sedation, prior to numbing the patient up. I like to say that you want to do the start bite right when the patient comes out of the restroom and sits down. Don't even have them laying back. They should be sitting upright. Restorative doctors, most of them are taking the bite registrations with the patient sitting upright. If you lay the patient back and try the start bite, you may have the mandible may go in a retruded position and may not be quite accurate. So what we like to do, once again, is this is prior to any sedation, patient sitting upright. And what I find works best is if you take and seat it to the upper arch and then hold it with your fingertips to the edge and then ask the patient to just tap into occlusion rather than don't try to dictate them into position. Just see how they tap into position. This particular patient is just going right into that home COCR position. That's ideal. Now, don't worry that if when you're doing this in the day of surgery, if the patient isn't hitting exactly right, it's just a reference point. It doesn't mean you don't do the case. It just means that if the bite isn't right, either the clinician who took the bite missed the bite, or maybe the laboratory unfortunately missed the bite. But either way, you're going to move forward with your procedure. It just means that you maybe have a little more adjustment to do on the provisional bridge, occlusal adjustments. But for the most part, if this hits, just patient goes locks right into it. Sometimes the patients are nervous. You may have to manipulate them. I think it's best just to try to let the patient just close into it on their own and see how that works. So that's the start bite, and this is going to be very important to do when you're using a bone supported monostrut. Now, if you don't know what that is, hang on, we're going to cover that. But please know that this is a very important step. So that was your first clinical step. Now you've gone ahead and sedated the patient, however you're going to do that, numb the patient up, etc. And we're ready to seat the bone foundation guide and actually just begin the procedure. So let's take a look at that. So in your exercise, we're going to ask you to go ahead and look where all those little crown boxes are and look for a box that's labeled metal strut pins. And there'll be three small strut pins. Remove those, and you'll notice that these holes here, this is where you can put dental floss through if you'd like, so that, if you accidentally, drop it down in the patient's mouth, it doesn't go down their throat, or at least you have something string on it. By the way, you should always be using a 4x4. I think 2x2 sometimes are too small, but I'll open up a 4x4 as a throat pack for the patient's safety. So remove those three pins. Now back to your larger box that you opened up to get your pre-surgical model. In there, you'll have these three items. So remove these three items. You're going to have your metal bone foundation guide. You're going to have the monostrut. This particular example that we're showing you is with a tooth-supported monostrut. And then you're going to have what we refer to as the bone reduction model. Okay, so get those three pieces out. Just pause this as needed until you get caught up. So let's take a look at the two monostrut variations. So on the one you see shown is the two supported monostrut. And we say two supported monostrut because, as you see, the monostrut itself is this large piece of plastic, if you will, that is supported by, in this particular case, was tooth number 6 and tooth number 10. Now, how do we pick those? The decision is made at the time of the go-to meeting. The designer will ask you, if you're going with a two supported monostrut, they'll ask you, are the teeth stable enough to support this? You don't want to have mobile teeth and try to seat this on because it could get malpositioned. So then they would ask you what two teeth. We like to use two teeth. What two teeth would you like to save and extract the remaining teeth when you're doing your flap? And so this particular case with 6 and 10 was determined. So the monostrut itself then is supported here by number 6 and number 10. We'll show more of this coming up. Whereas the bone supported would be for a patient who is edentulous or has terminal dentition that is mobile and not stable enough. And the difference here is that there will be three, what we refer to as a strut on the monostrut that fit over the alveolar ridge. And now I like to do this I'm a very visual person. I think it helps to see these things in surgery, like I mentioned, using the black Sharpie when you're trying to line up the pre-surgical model onto the bone cut model onto the pre-surgical model onto the working model. Um, Take a Sharpie here too, and just because not always does it fit like you see here. Maybe part of it, the guide, just because your anatomy of your bone. But I take a Sharpie and on the monostrut, I would just mark this with black so it shows up better than red and where it's touching bone. So when you're in the mouth, you want to see the same thing in the mouth. It just helps you to get this seated. Getting the metal bone foundation guide in the correct position is probably one of the number one key things to do to ensure that everything follows is accurate. If you, it's like the foundation to your home. That's why we call it a bone foundation guide. It's very important to get that foundation right. So you want to take your time when you're doing this little working exercise, dry model exercise, that you're checking all these things out, making the notes. I even take photos sometimes with my cell phone prior to surgery of things just to remind myself what it looks like when we're looking in the mouth. Um, so this is the bone supported one. The case we're doing here is a tooth supported monostrut. So when you're in clinically in the mouth, tooth supported monostrut, here you see the teeth are making intimate contact. There's a vertical stop, if you will. And well, as well, you're going to see the strut touching the bone, I'm sorry, the metal bone foundation guide, the metal, not the best view right here, but you want to make sure that you see the metal going over the bony alveolar ridge. So it's like a tripod. You have metal of the bone foundation guide on the crest of the alveolar ridge touching on one side, the metal over the alveolar ridge touching on the other side, and then your tripod, even though there's 2 points of reference here, will be on the teeth. That way we know we have it, you have it in the correct position. And you're going to see some more images because a strut as a belt and suspenders is we actually have one strut in between the teeth that you're retaining that will actually be touching the bone as well. And we'll look at that in a little bit more detail. So let's focus a little bit now on the bone supported monostrut. And again, what you're going to have here, the monostrut will have the occlusion here that's going to articulate to the opposing arch. If it'll typically be your same as the long-term provisional. Um, this is the bone cut model where the two supported, you saw there was two teeth on, there'll be two teeth on that. This one is just your edentulous ridge. So this represents bony alveolar arch right here. The tissue reflection will be somewhere way down here. This bone cut, so this represents how much bone this particular case is needing to have an alveoloplasty to that level. Then what you're seeing here on the right, once again, we're looking to make sure that you see the contact of that strut onto the peak of the alveolar ridge. Why is it important to make sure you did that start bite? Because the mistake would be made that if you didn't do the start bite, let's say the start bite was off, um, and you didn't check the start bite, so you really don't know that. And you're here now putting the bone supported monostrut, seating it. Well, you use the occlusion to help position it. Well, if you're kind of manipulating that to try to get the occlusion just right, when in reality the occlusion was off, you have a propensity of maybe position this in the wrong position and pinning it. So this is why it's very important to always check the start bite. The start bite's not a go, no go. So an example, if the bite was off, then you would know that when you're seating this bone foundation, the bone supported monostrut with the bone foundation guide, that the bite wouldn't be perfect. So this is a way just to help, ensure that you're following steps along. So in the mouth, clinically, what we're looking for is, again, always check to make sure you can see the metal of the bone foundation guide making boned contact. So it's metal to bone on both posterior extensions of the guide onto the bony alveolar ridge. And then you're going to see the strut contacting. I always like to make sure my anterior one's out here. Now, if you didn't do atraumatic extractions and maybe you expanded that bone, then keep that in mind. If you did do some expansion, maybe this buccal plate got expanded and it's holding the guide up. Well, you can go ahead and take a burr out of the mouth, of course, and you could relieve inside this monostrut um, here and just leave it where it's getting a vertical stop. What you're really looking for is a good vertical stop. Um, and so you don't want it to be engaging undercut. Maybe you expand the bone, it's not fitting over it. So this is why, if you've ever watched any of the other videos that I've done, we always talk about, atraumatic extractions because we're working off the CT that you gave us pre-surgically. And so all we can do at the laboratory is assume that this is where the bone anatomy, the physiology of the bone is, and we're working from that. Now, if that changes during your extractions, or maybe there was an infection between the time that the scan was done, et cetera, there may be some changes. So just be prepared. Sometimes it's not exactly as what it was planned, but work through it. And the information's there. Sometimes it's helpful, sometimes it's not maybe as relevant. And of course, I'm sorry, of course, we're going to be using the occlusion then to help seat it. So these are your 3 points when you're seating a bone supported monostrut. All right, so let's put this together. So here's your bone foundation guide. We refer to this as the BFG. And what I'd like you to look at is look to see that there'll be some areas, there'll be 3 points that'll always be flush. There'll be a hole here, and it's flush to the buckle, if you will, of the bone foundation guide. There'll be three other holes that will have some component of it that'll be protruding out. Now, sometimes it may be protruding out as much as 4 or 5 millimeters. This is all decided by the lab. It helps to determine the position of these anchor pins, and it's based upon how wide the horizontal width of your alveolar bone, because these anchor pins that you're going to utilize to fixate this bone foundation guide into position, we want to get bicortical stabilizations through the buccal plate into the palatal or lingual plate. So if it's a wider ridge, like this particular case is, then this 20 millimeter long pin, they don't, it needs almost that entire length to engage. And you'll see that coming up here. But sometimes this ridge is narrower, and so this will protrude out. So again, a 20 millimeter pin, we'll use some of it will be protruding out here, but still will engage that palatal or lingual bone. So what you're going to do then is you're going to look at your monostrut and look at these holes here. They will line up with the flush 3 holes. Sometimes this can be a little like a juggling act just because there may not be a lot of surface area here. We'd like to see that, so this first ledge here should seat onto there'll be like your vertical stop onto the top of the bone foundation guide. And then you would insert your metal strut pin here and do that with all 3 sites. So now you've secured the monostrut to the bone foundation guide with these 3 strut pins. Now, in your worksheet envelope, you'll be a page here that will tell you what teeth, if you're doing a 2 supported monostrut, what teeth to retain so you do not extract, for this case was 6 and 10. I think it's a good idea to take that sheet out and tape it into the operatory where everyone can see it, so that, because sometimes you get into doing the extractions and you get talking, or you're just, moving right along and accidentally extract the teeth that you're wanting to retain. So this is a nice visual aid. So now what you're going to do is similar to where you seated the pre-surgical model, you're going to seat the bone reduction model. So this is how much bone will be reduced, and these are the teeth that were being retained, and seat that onto your model. Once again, you could take a black Sharpie and darken these extruding pins out to help you see this quicker and a little more readily during the surgery in the surgical suite. So now with your bone cut model in place, you're going to seat the connected monostrut and BFG onto those teeth. And so it's going to be seated. Once again, you're going to see the incisal ledge making contact here on each tooth. You should see the monostrut making contact onto the bone in these areas. So you're actually getting multiple reference points here. If you should find that in the mouth, maybe during extractions, you fulcrumed off one of these teeth that you're meant to retain and it doesn't fit into the guide. If you can't maybe physically manipulate the tooth back in position, maybe the best thing to do is one of 2 things. Either go ahead and relieve inside this monostrut so it's just a vertical stop, or extract that tooth. You still have another tooth here. You have the monostruts here. So sometimes you may find it's beneficial to to remove a tooth and utilize the bone contact underneath the strut, like you see back here, to give your position. So it kind of depends. Maybe you expanded the bone during extraction and you expanded it out here and it won't let you get under the teeth. So maybe you go back now, as I mentioned earlier, and inside that plastic strut, out of the mouth, you take a burr and relieve that area, just leaving a vertical stop at the crest of the alveolar ridge here and just really remove all that buccal contact or maybe palatal contact. We try not to wrap that too far onto the palatal bone or the lingual bone. Then once again on the bone supported monostrut, you're going to see the similar thing here as we just previously showed. But this is what you're wanting to check. Again, if you're expanded that bone, this may be holding you up, relieve that area. So let's take a look at it clinically here. I think it's a good idea. I really strongly suggest you do this. After you think you've reflected enough tissue and you've retained the two, for this case was these two teeth here, try just the monostrut by itself in. This is going to help you to make sure that you did relieve enough to reflect the tissue enough, because if you didn't, then the flap would be caught here on the strut. And so I'm just playing that one more time for you. And this also helps to confirm that the bone didn't get expanded, because if you have it all connected together with the bone foundation guide and you go into the mouth and doesn't quite seat, it gets too many variables of what might be holding you up. So this way we're looking at it and say, it fits the bone real nice here, as you see the probe pointing to. You see the teeth are making nice intimate contact. So you know that the monostrut is accurate. So that's good. So the next thing we're going to do is, without the monostrut attached to the bone foundation guide, let's try in just the metal bone foundation guide. This also is going to make sure that you've reflected enough flap. And I found in the hundreds of cases that I've been chairside with, about 50 to 60% of the time, the clinician needs to reflect the tissue even more. It takes, some of these cases do have a very large flap. I will say this particular case, there was a lot of alveolar bone being reduced. Um, we find that the average with a patient that has terminal dentition is about 3 to 5 millimeters of bone that needs to be removed to get the proper restorative space for the final prosthesis. So what you're looking for when you're doing this try-in is you're making sure that you have the flap, of course, being released enough. And some clinicians may tie that back, as you see here, tie the flap back. Um, but you're really looking for, look how nice that is. Metal to bone contact, absolutely here. Metal to bone contact here. So we know, pardon me, we know the metal bone foundation guide. We get intimate contact here. Now, most often, you're always going to find some gaps between the bone foundation guide and the buccal plate of the alveolar bone. The reason for that is because the path of insertion of this bone foundation guide, we have to have a gap there. But you are going to find enough places that where you saw it on the model, you should see it in the mouth. So on that model, you would have seen that, yep, this makes good contact here. And you'll see sometimes the root eminence fits in nicely into here. So you shouldn't have any rotation of that guide. You might sometimes find that bone foundation guide might have some rotational horizontal movement on the lower more than the upper. And the reason I see that happens is because the lower arch, the root eminence is not as prominent as it is on the buccal, the maxillary arch. And so on the maxillary arch, as you see here, that actually becomes almost impossible. Well, it is impossible on this particular case to rotate that bone foundation guide because the root eminence is fitting properly in there. Sorry, I went the wrong way. Um, and so this is a way that you can just make sure, if the lower is rotating, don't worry about the lower moving, because that's what the monostrut's going to do, is help you get that final rotational position as well as the final vertical position. So again, by separating these two pieces and trying them in, it's going to make it more predictable, or at least minimize the variables. Because if you had a challenge, then you know that it's the bone foundation guide. Maybe you did expand that bone here and this is not seating. Well, go ahead and either do one of two things. Try pinching that bone back in the area that's not fitting. Or maybe you want to take a burr and actually on the buccal plate, maybe you can relieve some of that bone. Or it is okay to actually grind inside the bone foundation guide here. Of course, you do that out of the mouth and just take it out of the mouth and grind inside that metal. This is very strong. You can get that half the thickness that you see here in any given area, and it's going to be very strong. It's not going to break the bone foundation guide. So just get in and get after it. I mean, if there's metal holding you up somewhere against the bone, let's say at this particular area, just go in there and relieve that metal or relieve the bone. Try pinching the bone back, but make sure that you see this metal seating posteriorly. Anteriorly, like this, your vertical stop is going to be utilizing the monostrut attached to the bone foundation guide, and then that's where you're going to get your vertical stop. So what we're going to do is you're going to receive on if it's your first in sequence kit, we're going to give you your first set of what's called anchor pins. You'll get these free with your first kit. You're also going to get a drill I'll talk about coming up here in a minute to create if you will, osteotomy for these anchor pins. So these will be in the packet from the manufacturer. Now, we're utilizing the Nobel BioCare anchor pins as well as the Nobel BioCare drill for these anchor pins. We had to make a decision on one particular drill. And even though your guided kit may not be a Nobel guided kit, and they have maybe a drill for this, you do need to utilize this. And I'll talk more about this coming up in a couple of slides. So at this point for your dry model exercise, go ahead and get your 3 anchor pins. And then you're also going to want to have your driver, and it could be a hex driver, it could be a star driver, whatever your implant system is. And make sure too that you have, I say most all manufacturers make these drivers in a small, short, and long. You should have all 3 lengths. And that's just to make sure, because you'll have different variables and you don't want to be without the right tool. So make sure that you have all 3 of the sizes available. And very importantly, and this gets missed many times, I see this happen more often when specialists are doing the case and you're not used to any of the prosthetics, so to speak. When you need to seat a straight multi-unit abutment, there's a separate driver, a straight MUA multi-unit abutment driver that's required in almost all implant manufacturers to seat these. And those are separate from the guided kits. And sometimes they're even separate from a prosthetic kit, tooling kit that a clinician may order. So you just want to make sure that you have it. So this again is why we're doing this dry model surgery with you, to make sure you have the right components and not try to scramble around at the time of surgery for these items. So on your model now, you've seated your monostrut that's been attached to the bone foundation guide, and you're going to secure the bone foundation guide with your 3 anchor pins. Clinically, you would have drilled this, which I'm going to show that coming up here, using the drill that we'll talk about on the next slide. So here you're going to place your 3 anchor pins, and again, there'll be a sheet. I took this sheet and just kind of split it up, but there'll be an 8x10 sheet in your white envelope that will remind you that you need to have this twist drill. And so 1.5 by 20 millimeter twist drill. And this will give you your first one free. So if it's your first case within sequence, the go-to meeting, they'll know that. If they don't ask you that, be sure you can tell them that you want your first set of anchor pins and you want the drill. Also, if future cases, these drills should only be used on maybe one case for one patient at a time. The reason is that they dull very easily when you're going through all that metal in a bone foundation guide. You can do, an upper and lower if you're doing a double arch case, with that same drill. But just to be safe, get a new drill for each case. You'll tell the laboratory, hey, I need a new drill. They will charge you. If you have any discounts, they don't mark these parts up. Um, they'll bill your account for it. But or but here's the part number if you want to order it yourself. That's a Nobel part number. And then this is for the anchor pin. But again, if you try to overuse these drills, they get dull. You have a higher propensity when you're pushing through that buccocortical bone and you're trying to engage that palatal-cortical bone that you can, push too hard if they're dull and break the drill off. And that's not a good scenario. So this will just make sure you've got the correct drill and anchor pins. And so let's take a look at that, a clinical look at that. So we're seating the connected bone foundation guide to the monostrut. And be honest with you, sometimes I've actually found that it may be easier to leave the metal guide in by itself when you did the try-in, and then hold it in place, and then come in and try to attach the monostrut to it separately. You'll find what works for you best. But so once again here, we're just verifying that everything is seated properly. And now that we've verified that, now you're holding everything in place here. And we've already drilled a couple, but I'm just showing you. And you drill all the way, very importantly, to the little hub on that drill. So we predetermined, you notice how this portion of the bone foundation guide is protruding a little bit further than the one I showed you previously on the little hands-on, especially this one here protrudes even more. We make that decision in the design so that we know this 20 millimeter length pin that will make sure the tip of it engages the palatal cortical bone. So here we have all three of the anchor pins. You just can't see from, wait, here it is, 1, 2, and 3. Oh, look at this one, how long that is. So these three anchor pins will always remain in place. You do not remove those until you are done with the procedure. Now, that is, you fixated everything into position. And then the next step we're going to do is you can do the bone reduction and the implant placement. So once you've secured that in place, you're going to remove. You saw the video of the were plastic pins. We now have changed that to metal, which you'll have in your kit. So go ahead and remove the three small metal pins. Remove the monostrut. Again, you do not remove the anchor pins. They stay in place until you're done. So on your model in front of you, go ahead and remove the small pins, remove the monostrut, and then your dry model procedure would be to extract those two teeth and remove, and then do your alveoloplasty, which all you're going to do for your dry model is lift up and remove your bone reduction model, bone cut model. So clinically, this is what that would look like then. Again, you're going to have our metal pins here, and we're removing the three small pins. Again, good idea to always have a throat pack. And then what we have, you have your bone cut model. And so what you see here on the right now, we're saying that's a way you can compare to say that, yep, you know you got everything right because look, you need this much bone reduced for this particular area. Yep, matches here, matches here. I like to actually hold this up and do it before you do your anchor pins because that way, if you need to change anything, you might need to maybe freehand something. Maybe there's some bone did get expanded. But again, this is a visual verification that you've got everything in the right place. I like to see this metal here making contact over the alveolar bone. My thumb's, well, not my thumb, but the clinician's thumb is in the way here to show it here. But so we know we're feeling really good about this case. So now the next step would be to extract those remaining teeth and do your alveoloplasty. When you're doing your bone reduction, some people may use reciprocating saw, a piezo unit. Most clinicians will use a large burr, bone reduction burr, and you're going to take and you want to reduce that bone flat from the flat portion of the buccal, the bone foundation guide, to the palatal or lingual. You just want to reduce that flat all the way across. Then what you can do to verify that you've reduced enough bone, and we want to do this in your dry model kit, is remove your angle rotation guide. This one's, of course, is your maxillary one, and remove that. And this guide will have these blue lines. That's going to be for helping you line up the multi-unit abutments. If you had all straight multi-unit abutments, the label on that would say bone cut verification guide. Now, why we call it that is for this reason right here. We have found that this guide, because it has what I call a large footprint, a lot of plastic here, that it's really quick and easy to use in the mouth. I'm going to show that coming up. But on your model, go ahead and just take and seat that onto the bone foundation guide. And you're going to see that it seats flush all the way around. It doesn't rock on your model. And it should be the same way in the mouth. In other words, when you're doing this in the mouth, if you want to verify did you remove enough bone, you're going to seat the angle rotation guide, and it should be flush here, as you see, and shouldn't have any bounce to it. That way you know you've reduced enough bone. If it bounces, many times you can kind of tactically feel where that bone is high. Another tip for you is you can take a metal perio probe, and as long as you touch from the buccal to the palatal and run that across, you would identify that high point. And right where we are there, that's most often where there might be some bone holding you up if that's bouncing, because that would potentially keep your surgical guide from seating as well. It's back here, posteriorly palatal area, sometimes just ergonomically for you to do that bone reduction that maybe you don't get it quite right. So two ways to kind of verify that your bone reduction is good. Okay, so now let's go back to your dry model exercise. You've remove that angle rotation guide. Now remove your surgical guide, and your surgical guide is going to fit to the bone foundation guide the same way that the monostrut did. And here again, you're just going to line up the holes to the flat holes on your model, and utilizing the same three small model pins, you'll go ahead and secure the surgical guide into position. Now, if you'll note, there's some big gaps here, these square boxes, so to speak. This is where you can do more external irrigation should you decide that's necessary. And there's actually channels cut in on the integral side of these surgical guides to help direct the irrigation right to the osteotomy site. So that's a nice feature. If you haven't worked with us in a while, we've added this. It's been probably a year to 2 years that we've added these channels like that. So clinically, what does that look like that we're doing? And we're just making sure everything seats firmly into position. And you're going to know it's in the right position because you'll insert the pins. Now, if those small pins did not seat, then either most likely there is, again, yours will be metal, but if they're not inserting into here, sometimes it might take a little extra effort to push them, might need to jiggle, move the surgical guide around a little bit. It could be that either you haven't reduced enough bone and something's holding you up, or maybe the tissue is caught. Sometimes your throat pack, the gauze might be caught somewhere, might be holding it up. But these should all fit in flush as well, not just go in, but be flush here on each area. So now you've secured the surgical guide in position, and then go ahead and follow whatever your protocol with your implant system is to place the implants. Now, on your surgical guide, there'll always be, and we put it out to the buccal or maybe the mesiobuccal area, a blue line. This blue line represents where a flat, most all your implant systems are going to be an internal hex. And if they're not, there may be an internal lobe. But either way, there's a reference point where there is an index of when you're putting an angled abutment on, we need to make sure that we're doing that angle correction so that we're correcting. If you have an angled implant, prosthetically, we need to correct that angulation. Once we get supragingival or supracrestal, we got to bring that alignment back within the facial alignment for the teeth. So we'd use an angled, maybe a 17-degree or a 30-degree angled multi-unit abutment. Well, to make sure that we're angling it correctly, that you want to make sure that you put an implant into the correct depth and rotational or timing position. So this blue line is going to help you with that. So what you need to just do is know your system you're working with. This particular one is a Nobel placement mount that the implant is placed, and their mount at the time this was filmed has a hex. So each hex here, each flat of that mount represents an internal hex of the implant. And so what you're going to have is this metal sleeve here, the ring that we have in your surgical guide is set to the proper depth. So the surgical guide serves two things. It's going to give you guided depth positioning of the implant, as well as help you with the timing or rotational position of your implant. So the depth is going to be because your mounts are wider than this ring. So that's your stop. It can't go any further than that. So as you're seating this implant, slow down as you're getting this gap is coming very close here. Slow down, and you want to make sure that you split the flat of that hex with the blue line. So here we're flush, and you see the blue line is right in the middle. If you had that blue line lined up at a corner of the hex, that means that when the angle correction comes in, that could actually come out the buckle where your temporary coping or your screw access hole might come out of the buckle. It might come out too far mesially, lingually. Bottom line, it will come out in an undesirable position. So this is very important for our surgical friends that you know the nuances of the system, what these visual guides, visual aids are giving you, and the importance of them, especially on an angle. Straights are not that critical, but and it's can be challenging when you're posteriorly and you're on number three and you're trying to look back there, but you may have to, whether you're a stand-up clinician or a sit-down clinician. If you're a sit-down clinician, you might have to get up and lean over, look, get your assistant involved, have them take a look. But you really want to make sure that you verify that that blue line is in the center. Some systems might have some dots along their placement mount, but there will be a reference that you want to line up. So just make sure that you're getting that lined up. You're going to appreciate this when you get to the restorative or the prosthetic portion of this on the time of surgery when it comes to seating the provisional bridge. So now that the implants have been placed, now the next step, of course, will be to remove your surgical guide. Very simply remove your three pins and remove the surgical guide. Once you remove the surgical guide, what you want to do now is evaluate for whether you need to do any bone profiling. Now, some clinicians at the time of go-to meeting, it's your call. Do you want the platform of the implant to be subcrestal, or would you like to see the platform of the implant at the proposed bone reduction level? That's your call. But when you do have an implant subcrestal, it may be necessary to do some bone profiling. We find that very often that it does need to be performed when you're using an angled implant, especially a 30 degree. Why? That's because if you look here on the patients for this particular case, I believe we're at number three here, that the plan was to have the platform of the implant at crestal bone level after the alveolarplasty. But because it's an angled implant, the distal the distal portion of that platform is going to be subcrestal. Well, that could cause then that when you go to put the multi-unit abutment on, some systems have it wider contoured, wider cuffs of the multi-unit abutment that it could hit the bone and not seat. So this, you can see some situations here. We've got some problems here. So this case needed some bone profiling. Here we look pretty good. Here we look real good. Okay. So you want to do this because if you don't, and you start seating the implant, I'm sorry, start seating the multi-unit abutments, it may be difficult to see what's holding you up. And if it's not seated right, this is going to be a problem because you're going to cause some real problems for this patient when you have them leave with the provisional when it's not seated completely. So now we verify we've done any bone profiling that's necessary. Um, Now you're going to place your multi-unit abutments and the temporary cylinders or temporary copings. Um, Terminologies might be a little different with different implant systems. So what you're going to do at this point, it's up to you whether you place the straight ones first, but let's just go, or the angled ones. So go ahead and you can remove your crown boxes, lay them out, and I'm going to show you, this is what you're going to do for any of your straight multi-unit abutments. Most all companies are utilizing a plastic carrier. Some may have a little screw that is screwed to the top of the multi-unit abutment that is your means for carrying it from the crown box to the mouth. So you're going to need to have, so this is a carrier to get it to the mouth and just do your initial placement of it. But to tighten it, you're going to need to have the straight multi-unit abutment driver, which is kind of like a socket here. You'll see the female hex here. And those often are not included in the prosthetic kit, so make sure that you have that because you'll be regretting it on the day of surgery if you don't have that. So a straight abutment, were this particular case, all three of our anterior implants were straights. So you're going to seat that with the carrier, initially engage it. It'll only go to a certain part. Once it gets tight, snug, then that plastic will just spin over the top of the hex, that small hex here of the multi-unit abutment. So you just snap it off. You just bend it over, and then you would take your straight abutment driver and seat it over the MUA, and that's how you get it to the final torquing position. Now, these straight abutment drivers also have, you can order them to fit directly into a torque wrench. Some of you may have a system that the spring torque wrench might adapt to your hand driver here, or but to, based on the initial insertion torque, you want to make sure that you don't try to torque. If you only had, say, 15 millimeters of insertion torque, but you felt comfortable enough loading this anterior implant because the other ones had really great stability, then you'll want to make sure that you don't over tighten that one because all you can do is spin the implant. Again, maybe on a straight abutment, the straight implant position is not such a problem. But when it comes to an angled one, that could be more of a problem because if you tighten it and move that abutment, when you move the abutment, you're moving the implant. Now you're changing the angulation. So, and just in your little hands-on dry model, don't over tighten them. These analogs, we fixate them, glue them into place on your model. But if you try to put a torque wrench on your model or get too heavy-handed and try to really torque them on your model, you may spin your analog on your model. So this is just more of a physical exercise, mental gymnastics, if you will, to get used to what you're going to do in the mouth. So we got all three of your place all of your straight abutments. If your case has all straight multi-unit abutments, then you don't have to do this next step, but it's good for you to review this because maybe your next case will have an angled abutment. So go back to your angle rotation guide. And I want to say this, that the angle rotation guide is a visual aid for this particular portion of the exercise. We used it earlier on to help you verify your bone cut, but right now it's being utilized as a visual aid because if you've never done these cases before, seating an angled multi-unit abutment in the posterior can be very challenging. And so, I'm going to share with you multiple things that can cause you some challenges and maybe how to overcome that in the next few slides. Hopefully you'll find this helpful for you. So first off, let's explain the purpose of this angle rotation guide. Your model, if you look at your model here, as you see on the left, you're going to see that there's a blue line. This particular model has some blue lines here. Wherever there's an angled implant, there'll be a blue line. Now, notice how far the distance is from this little blue line on the bone foundation guide to the top of the implant. That's just how it's designed. We can't help that part. As opposed to over here, this implant site is really close to this blue line. So what am I saying here? What I'm saying is that when you have to line up the multi-unit abutment, and you're going to see that in the next few slides, that you want to line up the screw access hole of the angled abutment to that blue line. Well, that's kind of a long distance here to try to visualize in the mouth. So when you seat the angle rotation guide, what that does, it brings that blue line from the outside edge all the way right up near the top of that platform of the implant. That way, it'll make it much easier for you to position it. So now this is a multi-unit abutment. This happens to be a neodent system. And I think you'll find that the Straumann SRA is their reference for that, is also like this, more of a tapered abutment. But either way, you're going to see the screw access hole. Here's a carrier. So your multi-unit abutments angled, okay, angled, will have a carrier that's screwed to the top of it. This screw access hole is where the actual abutment screw goes through the abutment and engages the internal threads of the implant. And so what you want to do, now this is very important. So you as a implanting clinician, whether you're an oral surgeon, a periodontist, and you're not used to doing prosthetics, this will be very important for you to get correct. So when you're placing that abutment, you want to line up that screw access hole to the blue line. And we have many clinicians say, well, why don't you why is it put so it's back in the posterior? I can't see it. That's how it is. I mean, the implant's angled at 30 degrees to avoid on a maxillary arch. We're avoiding the sinus, and we can't help that. That's just how it works. So you're going to see here now that screw holes lines up nicely over that. The other way you can make sure it's in the right position, you want to look for a couple of things here. One, that if it's a 30 degree, engaging your driver, it should be about a 30 degree here from the carrier, or it would be 17 degrees. Your two options for a multi-unit angled abutment is either a 17 degree or a 30 degree. And we do find most often in the posterior maxillary, you need a 30 degree because many of the times we are avoiding the sinus, or what could be happening is we're increasing that angulation like that to increase the AP spread, the anterior posterior spread. So that way it's more biomechanically foundationally sound for stress distribution when we can spread those implants out a little bit. Okay. So another thing to look for, and this means you have to get up, look around, maybe get a mouth mirror, ask your assistant, what do you see from your side? But I'm trying to show you here is the shaft of your driver that you're using should fall directly over that blue line because it's engaging that screw head, which would just automatically put it right over the blue line. So look to see you have that. And then the other thing that we'll find is that the carrier itself should usually it's pretty darn close to 90 degrees to the bone foundation guide or to the alveolar ridge. Not always exactly 90 degrees, but it should be pretty close to that. So here's what I want to share with you. All right, so let's say you're only looking from the front, from a buccal view, and you're going, yeah, look at that. That carrier looks pretty good. It's right down in between the alveolar ridge. However, when you come around and look at the buccal, you'll notice that it's way out, and that is nothing like what we want to see. And that's going to cause your screw access hole to be in a very undesirable position in the prosthesis, and it may be actually impossible to get the screw into that provisional because the path of insertion is so far posteriorly, and you have to have a driver. there's no place for you to get it. The anatomy will not allow for that. So, and then here's the other thing that can happen is so that's way angled. Well, the other thing that happened, that screw access hole now is way out here out of the buckle. So once again, you would have to come in, through the cheek almost to be able to get that driver and the screw to seat the coping or seat the bridge in the mouth, the provisional bridge. So this is what you don't want to see. Now I'm going to share with you something else that's very important, and this is what people don't understand many times about multi-unit angled abutments, and that is this: that you know, in sequence tries to always put the uh, abutment screw into the multi-unit abutment and attach the carrier. And so this is the correct, uh, the way it should look. Now, sometimes in shipping, maybe this comes out, maybe the lab did miss inserting that screw, or let's say that the carrier is not attached. Either way, I'm going to walk you through something that's very important. And I've actually had clinicians that didn't know this and they abandoned the surgery and just closed up because of a very, very simple nuance to this angled abutment that they weren't aware of. So what you should see, here's the carrier seated, screwed into the top of the MUA flush. You do not see the head of this screw. You see the threads sticking through. So once again, here's the thread sticking through, that's correct. And the driver is flush. I mean, the carrier is flush. If you look closely at your multi-unit abutment, the threads of that carrier are actually protruding into this area. Now, where the problem can lie is that if the carrier was screwed all the way flush to the multi-unit abutment, and then you try to place the multi-unit abutment screw, I want to pause for a second. I know I'm throwing a lot of terminology out at you. These parts do all have names. And so, you know, I'm doing I'm repeating this several times so that again, repetition creates certainty. This is so great that you're doing this hands-on dry model right now, so these won't happen to you at the time of surgery. So what you see here is not correct. The threads are not protruding through here, and you would not be able to seat this abutment in the mouth. And that's what happened to one of the clinicians that called me up and said he had to abandon the surgery. So what you're seeing now is I just did a little cutaway here. There's your threads going into that. So see, it's a thread that's holding that head of that screw up. So what you're going to do to correct that is you're going to loosen, back off the carrier screw so those threads come up out of the abutment. Then you're going to take your driver and turn the screw until it goes all the way through so the threads come out the bottom of the multi-unit abutment. So many times there's the internal threads of these multi-unit abutments that this screw has to be screwed through it. So that's why I say that to get that screw all the way down, you may have to take your driver and screw it down with this, making sure this screw here, as you see over to the right now, that's not in your way. So by unscrewing that carrier, now you've got that chamber wide open. You can get your driver in, you tighten the screw, not tighten it, but you seat the screw completely into the multi-unit abutment. Now, once again, this is correct. You see the carrier is flush, the threads are through here. Now this is the correct position for placing the multi-unit abutment. So thanks for hanging with me in there, but that's a very important, and that can cause a lot of frustration clinically when you're doing this at the time of surgery. So this is again, we're going to just kind of show you clinically utilizing that. Now, this case, I don't know necessarily if I wasn't filming this for training that we would have actually used the angle rotation guide because the metal did come fairly close to that abutment. But here again, we see that looks pretty darn perpendicular, the carrier. So that feels pretty good that we're in the right position. And you see that the screw looks like it's lining up, but also maybe hard to tell, but the driver is right over that blue line. So this is, if you think back to how I was showing you in the other pictures, that the driver went over the blue line, these carriers look almost perpendicular. Again, this is for your angled, okay? And then once you have that, you can go ahead and you can remove your um, little carriers. So if you want to go ahead and do that, just remove your abutment, seat that, and do that on each of your angles. Again, if you don't have angles, skip over these few slides. So I'm just showing you again. So here's number 3 in this particular case, lining everything up. Again, light finger pressure, and then repeat with whatever, all your angled abutments. So once you have all your angled abutments on, we're ready to put the copings on. So I want to share something else, a little tip with you. Let's say that you're in softer bone, but you're still comfortable that you got good stability to load the case. And now you're going to, remove your carrier. Sometimes these might get a little bit too tight, maybe from the manufacturer, but it's called counter torque. You can take a hemostat or a cotton pickup and just clamp that, squeeze it around the multi-unit abutment, and then unscrew your carrier. That way you're not putting, if it's tight and you're trying to unscrew that, you're not putting torque trying to unscrew the implant because the abutment is tightened into the implant. And if you start turning that too hard, you may actually rotate that implant. So this is counter torque to help you to make sure you don't move that implant when you're removing the carrier. Again, I think you all realize that you can always back up, pause, back up, replay things if I got going a little bit too fast for you. So now you can remove your angle rotation guide. It's served its purpose, and your model should look pretty similar to this one. Similar meaning you may have different implant sites, etc. Um, Again, just look at here. So on this patient's left side, I think this is number 14 for this case. That blue line is so close. If I had all my angles, or if that was my only angled one, I probably wouldn't use this rotation guide for seating the multi-unit abutment. It may just get in my way more than anything. But here, that distance is a little more helpful to get that blue line really close up to that. So hopefully that makes sense to you. Now, I'm gonna just switch gears real quickly here for just a couple of slides. If you were doing a Simply Guide Plus, which we're seeing more clinicians doing when they're doing more of a digital workflow, or they want to have a provisional delivered the next day or after surgery for more, like I say, the digital workflow, or they want to print, the clinician wants to print the provisional at the day of surgery in their own office. Different reasons for using a Simple Guide Plus. I'm not going to go into them in this procedure, but I want you to be aware that that's something that we have another presentation that you can get that will cover this information. But when you do a Simply Guide Plus, you're just getting a bone foundation guide, the mono strut, be it tooth supported or bone supported. You do get a rotation guide. If they were all straights, it would be your bone cut verification, and you get a surgical guide. You do not get any of the prosthetic components. They're not prepared, because we'll pre-cut the tops of those copings when we do the fully guided, which we've been showing so far. But if you were doing Simply Guide Plus, the kit, the Simply Guide Plus system, the kit would take you to this point, as you see in the left, to being able to seat your multi-unit abutments. These actually have the healing caps on the multi-unit abutments. This is now, for all practical purposes, with a Simple Guide Plus, you're done with our system. You would remove those long anchor pins, and then you could bone graft, close, and do your prosthetics however you want to do that. Again, we're not going to cover that. I just want you to be aware that this is kind of the difference with Simple Guide Plus. There's more work for you to do on a prosthetic end than there is when you're doing if you're doing that in a digital workflow. So now the next step is going to be seating the temporary copings or temporary cylinders onto the multi-unit abutments, getting ready to pick up the long-term provisionals. So you're going to have, again, whether it's a screwdriver, hex driver, star grip driver, SRA driver, whatever the name your company has, make sure you have the drivers. There's be a small prosthetic screw. This is the most generic name that I can find for that small screw, but it's a prosthetic screw. And then your temporary cylinder or temporary coping. The base is almost always wider. That will go on top. So the occlusal is in more the narrower end. Of course, the screw then goes through, as you see here, and the driver engages through the screw that way. As I mentioned before, they're available in different lengths. Most companies will have them in three lengths. You really need to have all three. Order them. If you're doing a latch driver and want to use like an outside contra angle handpiece, which are great to have, strongly recommend that you get those. Again, have all the lengths you need. It's terrible to get in a situation and not have the right tooling. Uh, it's too frustrating for you to deal with that. So uh, make sure you have all the right tooling. All right, so here, I'm going to share with you a way that works very well for me. Um, and I've done it hundreds of times. And so this is what I recommend doing. So seat your first temporary coping, and I would do this in the posterior, whether you do left or right, most posterior implant site, that's not relevant. But I do find if you seat one posteriorly, what we're going to do is we're going to start trying in our LTP with just a few copings at a time. The mistake people make is to put all the temporary copings on at once, then take the long-term provisional and try to seat it. And often it may not seat, and you're at a loss of, well, what's holding up? Where do I need to adjust it? So what I'm going to share with you is a technique. And if you do this, on your dry model, please note that, I mean, this should fit perfectly fine on your model, and you get to the mouth and you may have to make adjustments in the mouth. I'm going to address that as well. But it's only because, in the mouth, things will be different. Maybe you did tighten it a little bit more than you planned. An angle might be off a little bit. That coping might be hitting the wall of the inside of the temporary coping, I'm sorry, of the long-term provisional. So you still may have to make adjustments, but I'm sharing you with a protocol that is probably the best protocol that I found that works. So you're going to again, you're doing your dry model surgery here. So don't over tighten these. And I actually wouldn't over tighten these too much in the mouth. Just snug them up, even if you were doing this clinically in the mouth. So now you got one seated. Now seat the second one right next to it. All right. So just go to the adjacent coping. This particular case is going to be the number six position. And now go ahead and you're going to take out your one of your long-term provisionals. You do receive two of them, unless you requested not to have two. And what we're doing is we're just trying on the path of insertion. This is very important to do in the mouth, uh, because this is where you want to make sure that you get the passive fit. So now you're going to seat just the two. And what you're looking for here, get used to how you're going to see it on the model. You want to see a gap all the way around between the wall of the long-term provisional and the cylinder or the coping. And just make sure also that when you're doing these try-ins, that the ledge touches on the metal and that you're seating flush against your bone foundation guide with the arms of the provisional. So clinically, here's what we're going to take a look at. We placed one. Now we're going to place the second one. Again, good idea to have a throat pack in place, too easy to drop something. Just light finger pressure. And then now we're going to take the provisional and seat this over the two copings, lining up the arms to the holes on the bone buckle, the bone foundation guide. You don't need to pin this. You're just holding it in place and you're evaluating to say, yep, I got some space all the way around here. You can't see here, but there is good space here as well. And so that looks great. So that took, 15 seconds to do that. But now then go ahead and you would add your next coping and repeat that. Try on your bridge. But let's say that in the mouth you're trying it on and you saw that either it's touching and it's not seating, or you don't have a space. You must have a space between the coping and the internal wall of your bridge. The reason for that is when you're going to inject your material to bond the coping to the provisional, you have to have a gap because it needs to go around. If you doesn't go around that coping, that is a complete weak spot and a high propensity of fracturing if this occurs. So you must create some space here. And again, the reason you may not have space is you didn't line up the implant through the surgical guide, splitting that flat of the hex to the blue line or lining those things up. As I mentioned previously, this is where that comes back to haunt you, is if you don't do those steps properly in the beginning, it's going to catch up to you here. As a specialist, if you're doing the case, this is your restorative doctor, maybe chairside doing it. Well, maybe you don't have to deal with it, but they have to deal with it. And that, so once again, if we just, I love the name in sequence because it is step by step in sequence. You follow that. Hopefully, you have a really nice experience with this. So this does not have enough space. So what do? You would mark that. And then if you have your two bridges, I would mark both bridges. This is just kind of jumping to we were in the mouth and we mark that and then go ahead and adjust that bridge and also adjust that second bridge in the same place. This will save you time because you're gonna see if this is your first case, we're going to pick up both of these temporary long-term provisionals on the day of surgery. So that's just a tip for you to take a little Sharpie, mark where you need to relieve it, go ahead and relieve it, and then add another coping and just each time add a coping, try the bridge on, add a coping, try the bridge on, and evaluate all sites because one site may have been fine. And then when you add a coping on, it may have kicked it a little bit. And maybe now you're hitting over here. So this is just a good exercise for you to do. Here we have on your model, all your copings are in place. In the mouth, you'd want the same scenario in the mouth to see that everything has space around it. If not, create that space. And your model now in our dry model protocol should look similar to this. Um, the next thing we're going to do is we're getting ready to pick this up in the mouth. So we want to remove the gasket, the tissue gasket. It'll be marked maxillary gasket or mandibular gasket and remove that. And if you look at that, you're going to find if you hold it flat in your hand, if you look right straight at it like this, there'll be a little concavity. I'm sorry, a little concavity to one side. If you flip it over the other, it might have be flat or a little slight convexity to it. The concavity portion you'll find will go toward the occlusal. So let me kind of show that to you here. So if this side I look like more of a concavity to it, it's sometimes not real easy to see, but you're going to seat that then over the temporary copings, take an instrument, push it down all the way down. If it's not fitting, then take and flip the gasket over. You may be just having the wrong position. So usually it only fits the right way. Sometimes it may fit both ways, but it's irrelevant as long as it's fitting and you're sealing off around each of these temporary copings because when we start to inject the acrylic, the last thing you want to have happen is for acrylic to get down around the undercut of the multi-unit abutment and lock in or get down into an extraction site, capture some bone. Bottom line, lock your provisional into position. That is some of the worst things to deal with from a prosthetic end on the day of surgery when you lock in a provisional. So get these, again, make sure you're doing this portion properly. If you're the specialist watching this, I would say, send this link to your restorative doctor. Tell them they need to watch this portion of this video. So let's take a look at that in the mouth. So, and it's good to also dry off those temporary copings. A little bit bloody here. I would like to have had that a little, cleaner. When you're filming these things live and talking, it's sometimes you miss a couple little things. I would like to have seen that gasket pushed down a little bit further all the way down. Um, So here, I think it's also a good idea if your gloves are real bloody, wipe them off because you can get a little bit of blood in these injection holes, and all that's going to do is leave a little red line that you're going to have to almost do a repair on it to deliver to the patient. Otherwise, it's going to look like they have a little blood spot. Blood spot. So keep things kind of dry and clean will be helpful. So now the gasket's been seated. We're taking now seating the provisional into place. This is one of our older styles where we had an extension that filled fit into a box, into a groove. We quit doing that because that also made it longer. And many clinicians didn't want to have that bone foundation guide extend that far back. So yours will not have a big long extension here. There'll be just a little extension off the posterior here, but the same idea, making sure that everything gets pinned in, fits, gaskets in place. I like to put a light coat of Vaseline on these teeth, um, not in the holes here, but over the teeth because it's too easy when you're injecting this to maybe get a little spill or overflow onto the tooth, and that acrylic will bond to it, and it makes more of more work and can really be a problem trying to grind that off of the tooth for aesthetic purposes. So a light coat of Vaseline over the teeth. If you get a little flash of that acrylic, it'll just flick right off. So now we're ready to pick up the long-term provisional. So if you look at your provisional, you'll notice that there'll be an injection hole at each implant site. Um, so and some of them will have, more of an angulation where you're going to go. So when you're injecting, as you can see coming up here shortly, that you want to kind of point your syringe in that direction. So here we are on the model. And so for doing our dry model one more time, you would go ahead and now pin your long-term provisional into place with your rubber gasket in place. Okay, and the last thing you will do is you're going to use your blackout plugs. Now, the blackout plugs could be a little different based on what implant system. We've found the diameters might be a little different, so we've had to come up with some different plugs. Some might be more of a plastic straw versus this. Some might be a little green that we custom make out of some um, PVS material. But either way, the blackout plugs would go into place, and now you'd be ready for luting or bonding. Okay, so you're not going to do that on your dry model surgery. So this is as far as your dry model surgery review is going to take you. So then at this point, just go ahead and you can disassemble your model, put everything back into your kit. You want to keep everything organized. That way, when it comes time the day of surgery, that you'll have everything in a nice organized fashion. And if I would suggest that we've created something that's available for you, you can either go to this is the website. It's a YouTube a link. If you ask for a PDF from myself or from of our reps, they'll send you a PDF, and this will be a hyperlink on it. That hyperlink here, or if you go to YouTube and just type in the name of this, the title of this is In-Depth Surgical and Restorative Guidance for Full Arch Rehabilitation. You type that into the YouTube, and what's going to come up is a recorded 2-hour webinar that I did. That's probably the most in-depth that I've done. What I've been sharing with you on your dry model is a combination of that with more in-depth on the clinical aspects, as well as really a lot more in-depth on the restorative. So what you're going to get with that PDF is there's a table of contents here. And what I did is I took the entire length of that video is 1 hour and 58 minutes and 8 seconds. And I put time codes or chapters, if you will. So if you wanted to watch, say on the day of surgery, seeing a provisional, you could fast forward that presentation from YouTube, fast forward to 1 hour, 50 minutes and 54 seconds. And for 2.5 minutes, you'd be able to watch the seat in the provisional. For the restorative portion, you'd go to this area if you wanted to see bone reduction, etc. So these are time codes just to help you to get in and out real quick. And I always recommend that you share this with your auxiliary team members as well, so they can review it ahead of time. It may be the first time they're doing it, they're seeing this. It's better to see it ahead of time versus the day of surgery. The more information they have, they really do appreciate seeing this as opposed to seeing it for the first time live surgery with the patient. So I really hope between all this information that I've shared with you that this is going to be beneficial for you. Here's my contact information. Please feel free to reach out to me if you need additional information. Contact the laboratory. We appreciate your patronage. We're here to support you, and thank you very much.